Thank you. So hopefully after this, you guys get rid of me. So Angiosome Director, does it have a place in my practice? The simple answer is yes. These are disclosures. Now, challenges of endovascular treatment, we all know what they are. I want to focus on this last one, and that's difficulty in determining the threshold for adequate hemodynamic improvement to the affected tissue. We really don't have a good way besides angiography to know that. To do that, you have to take the patient off the table to do ABIs, TBIs, and things of that sort, pedal acceleration time. So aids to improve decision-making, obviously angiosome-directed revascularization has been proposed. A lot of data on it. I'll show you some of it. You've seen some of it already. Defining target artery pathways, getting the TAP is getting into our lexicon, and then a multitude of methods to assess the target tissue perfusion or flow in real time. There are a number of technologies out there. You see one of them that we use today. The correlation between anatomic complexity and outcome has been well demonstrated in the literature. And the revascularization strategy and outcome for open bypass, the angiosome-guided therapy has limited usefulness in open bypass for a variety of reasons, one of which is that the conduits and bypass are very efficient. And that usually is the case, as opposed to endovascular treatment. However, evidence suggests that there is some advantage to this direct revascularization through angiosome concept over indirect revascularization with or without collaterals. And you've seen this slide earlier today. The direct versus indirect plus collateral is an important concept. I think we need to keep in mind that collaterals do play an important role. Although direct revascularization is better than indirect, but with collaterals, it seems that in terms of wound healing, the impact is the same. If you look at this patient on the right side, there's an indirect revascularization through that perineal, and if the patient had a heel ulcer or toe ulcer, it would be fine because of that robustness of that collateral. The picture on the right side, which I cannot play, unfortunately, would have shown you that we do need direct revascularization. So if you guys can click on that thing, because I don't have a way to do that. That would be okay. Otherwise, we move on for the sake of time. Basically, the image on the right side shows very poor collaterals, and you need direct revascularization. Same thing in this case. For example, if this patient had a heel ulceration versus toe ulceration, would be a very different strategy in terms of direct versus indirect revascularization. So if this was a heel ulceration, okay, the posterior tibial artery revascularization into the lateral plantar would be fine. This doesn't really help us a whole lot in the toe ulcerations, as you can see here. So typical intraprocedural issues that we face are the same questions we talked about. Have we done enough or not? For example, in this case, you get a dissection. Is this hemodynamically significant or not? Does it need to be stented or not? These are the issues that really we don't know at this point because we don't have a good way of measuring. So we use this device FlowMed system that gives you uses the laser speckle imaging to measure actual flow. And what you get is you get a number that's based on based on the amount of flow, basically the amount of red blood cells or blood cells that pass, and waveforms. And these are the types of sort of images that you get. And I want to show you a example of that. This was verified in a 100-patient study, 167 limbs. And as you can see, a very good correlation of what we find on the FlowMed with toe pressures. In fact, better correlation to toe pressures than with ABIs, which has also been correlated clinically that toe pressures are more sensitive than ABIs as far as CLI patients are concerned. And you can actually get a color-coded sort of representation when you use the system, that if you're on the red side and the lower numbers, then you're in the CLI range, and above it, you're in the healing range. And here's an example of that, the anterior tibial artery and the perineal artery diseased. We went after this and, of course, was treated. This is early on. The signal that you get as we angioplasty that anterior tibial artery, you can see improvement of the flow above the red line. And then when you catheter remove, you can see even further improvement. This is a very sensitive system. But there is a recoil right there. And so should we treat this? Should we stent it? What do we do with that? And so this was treated as you can see, with further balloon angioplasty, larger balloon. And now let me show you what happened to the signal. Significant improvement in the signal just by treating that recoil. So this is the type of device that we have not had access to figure out what the physiologic hemodynamic consequences of what we do are. Now we have these types of devices available. So hopefully just going by angiosome alone would not be relevant anymore using that. And as you can see, this initial patient was stented, and we saw significant improvement. So conclusion, intraprocedural monitoring of blood flow is an important step. We happen to use FlowMet or other devices available, and this will probably do away with this angiosome concept, which we are basically guessing. Thank you.